I'm going to talk about what are the things we can do if we want to stay away from the vitreous, or if we want to use the iris as a support when there is no bag. So as we'll see in this instruction course, there is definitely hope for all those patients who don't have a steady bag and they need a good post-operative outcome. And I think as a cataract surgeon, we should have at least one of these things well versed with, because we need to know how to fix these lenses when there is no bag. So the iris can be used as a fixation support when you know that the bag is sooner or later going to become dialysed or get lost. For example, in a case like Marfan's, where there is a progressive zonulopathy, or in a traumatic cataract where you know that more than half of the zonules are absent. But most commonly, I think a fixation to the iris can be done if there was a primary surgery done and then that lens has now dislocated, and if it's a 3-piece lens, it's even better. But before we go into the depths of the surgical techniques, I wanted to share some of the meta-analysis that I found while I was researching for this talk that has been published. Now, this will help us understand what we can expect in our patients post-operatively. So long back in 2003, when there wasn't much evidence between comparison of different procedures, they concluded that the anterior chamber lens, SF-IOL and iris suture worked fairly all right. Then came the case series from Condon et al., who looked at the possible adverse effects of a foldable PC IOL with a mechanical suture, where they sutured it to the iris, and they reported good outcomes with very few adverse effects. Now, their reasons for use were mainly, aphakia due to loss of capsular support and dislocated cataract, or even IOL. Then over time came the case series which compared the iris claw lens to the iris suturing in Marfan's eyes, where they found that the anterior fixated iris claw showed more endothelial cell loss, which we expect. But this was an anteriorly placed iris claw, mind you. Then the study in 2012 showed they wanted to look at the CME that may have been there after an iris fixation, and they found very low cases, almost no cases having CME, chronic iridocyclitis, even IOL subluxation, pigment dispersion, or glaucoma. A recent case series done in 2023 has concluded that the iris suture fixation gives good outcome provided there is some capsular residual support. So this they found to have a very low side effect profile. They found that the refractive errors tended to be more myopic. Now that makes us understand we need to kind of titrate the IOL formulae that we may need to use. And then the latest meta-analysis compared the SF-IOL, which we have already heard by great surgeons till now, versus the retropupillary iris claw. And they found that the SF-IOL resulted in a better post-operative visual outcome compared to the iris claw, but it was quite time-consuming. So the complication rate, again, they found was quite similar. So I think the evidence suggests that if we are surgically well-versed with one technique, it will work well. So let's learn how to fix a lens to the iris. Now, there are some basic principles we need to follow. Since we are working at a plane where the vitreous may be disturbed, it is better to clear it away before we begin any of our manipulations. Now, like all the great vitreoretinal surgeons here, we would then think of doing a core vitrectomy or peripheral vitrectomy, or if you have a VR surgeon near you, they can help you with that. But if you've landed up in a problem in your primary surgery, and if you're away, wanting to stay away from it, a minimal good anterior vitrectomy should be all right. Depending on the type of fixation we need to do, we have to keep our instruments ready. Today I'm going to talk about two ways to fix the lens to the iris. One is the retrofixated iris claw, and the second is a 3-piece lens which I will suture to the iris. So you will need only 5 of these instruments, one plus or minus. So what we have here is the iris claw holding forceps. You will definitely need the 9-0 Prolene suture. You may need a spatula to just kind of help you guide things inside. Micro forceps to maybe hold the lenses if they are going behind the posterior segment. And then an anterior chamber maintainer. I think that is a small instrument which takes you a long way because it keeps the anterior chamber quite stable. So the iris claw was introduced way back in 1972 and fortunately has undergone several modifications, going from the anterior chamber to the retropupillary plane, and also by changing the convex concave optic now with a vault. Yet it can have a lot of complications like ovalization, the dislocation, if it is not tucked properly. And both of these complications are definitely linked with a lack of expertise, and therefore it fortunately gets better, because more and more you do, you are going to get better. Now today we have several options of iris claw lenses available in India. While most of them have similar optic designs, you can choose to have different sizes. So if the white to white of an eye may be abnormally large or abnormally small, you can definitely ask the manufacturer for a different size. Now, an iris claw lens can be implanted through a clear corneal incision or even a scleral, but because it needs at least a 5.4 millimeter size, it is better to take a scleral incision to reduce the SIA. The first step would be to clear the vitreous away. Now, this was a case where there was a total subluxation into the vitreous of a lens, so I had my vitreoretinal surgeon do the primary vitreous clearing after I had made the scleral tunnel. Here we, like in SICS, we do the tunnel. We make sure we don't open it until we have made sure that the lens that is behind, in this case, was taken away. So the primary surgeon is doing his, vitrectomy. He is going to make sure that the lens floats up. Just going to go a little bit ahead. So all the ports have been put. This was a complete bag eye with a CTR ring in place. It had completely subluxated. Okay, I'm sorry about that. So what we have done in this case is we have cleared away the subluxated lens back complex. We've taken it out. We've resutured the scleral suture, or rather we've just cleaned all the ports, and all the vitrectomy probes have been taken out. Now we have to inject pilocarpine. We need to make correct side ports, so imagining how we would like to hold the lens later on, or how we would like to manipulate the tucking, and that's where you will make the ports. Before we implant the iris claw, it is important to check the claws with a spatula to make sure that they are open, otherwise you will be in a disaster if it doesn't tuck in later. The iris claw, once implanted, so slowly it's going through the scleral incision, and it's inside. Once it is put in, you have to dial it perpendicular to the incision. You can even hold it by the forceps while doing so. Here I am doing it with a dialer. And once you have dialed it in the position that you want it to finally stay, you have to now hold it with a forceps. Now these forceps come with a lock, or they can come without a lock. Some might prefer it with the lock, because as a beginner, if you are going to fumble and the iris claw may move, the lock kind of helps you with that. Once you tuck the claw behind the iris, you have to then slowly use a spatula through one side port and then tuck it with the peripheral iris. It is important to engage the peripheral iris and not the center, to prevent any ovalization or peaking of the pupil. Through the same side port, I go to the other side, making sure I'm holding the iris claw a little posteriorly so that the endothelium is protected, and then similarly tucked. So this is a locked iris forceps, holding forceps. So you can see me that I'm trying to remove the lock, and also trying to pull it to see whether I have tucked it correctly. Slowly, all these maneuvers are very, very slowly done, so that we know that we are not pulling the iris a lot. And then once it is outside, all we need to do is clear the anterior chamber of any viscoelastics that we may have injected, and put the scleral flap back and the conjunctiva as well. I think it is a very simple procedure, which if perfected can give you great outcomes. Now this is a video which shows us how to untuck the iris claw if we ever need to explant it. There are not many conditions where we may need to do so, because iris claw lens, in our experience, which we have done maybe in our center, we have seen patients having iris claw for more than 15-20 years, and they have done really very well. But in case that there is such a need, you need to hold the iris claw from the place that it may have gotten disengaged. Make sure you put some viscoelastic under the iris. Through a side port from the opposite side, take a spatula and go under the claw of the iris, and just do a reverse procedure to untuck it. And this is very easy, and that's why we wanted to just show it here. Now, what's the beauty of iris claw is that it can be directed in any which way that we want. So you can even use it in a case where there is a iris coloboma or even a defect because of any kind of trauma that the patient may have had. So here what has been done is there is a iris defect because of a traumatic trauma in the past for the patient. This is not a coloboma actually. What you could also do is implant it and then do an iris repair if the defect was not so big, but in this case the defect is quite big. We have done the iris claw implantation in the regular normal way that I showed in the first video. After this, we would have either, if the defect was a little less, we would have planned for a pupilloplasty, but here we are refashioning another pupil because the iris is way below the normal pupillary area. So what you can do is create a new pupil with a vitrectomy so that the patient has a fairly good vision after surgery. The iris fixation suture for an IOL can be done if it's a 3-piece lens or if it's a single piece PMMA. So the goal here is now to loop the haptics with a 90 Prolene suture and we fix it to the peripheral one. This was a referred case where a 3-piece IOL was implanted in the sulcus, probably after a PCR, but over time the lens kind of subluxated and then the patient had poor vision. So our plan here was to suture the haptics to the iris. And after checking, for if we want to take the lens out, but it seemed fairly stable. And like one of the articles also told us that if there was some residual capsular support, it is going to help you during the surgery because you don't want the lens falling down. So that capsule is going to keep the 3-piece lens there when you're trying to do all your maneuvers. So here we've put some pilocarpine. We have to make sure that there is no vitreous. Here I'm using a spatula and a dialer to just tuck the optic of the lens in front of the iris, and the pilocarpine has already kind of constricted it, so it gives you a nice space to sit on. You will take the side ports where you expect the suturing to be done. So this should be done at a peripheral iris place. We are using a straight needle 90 Prolene. You can slightly curve the tip because you need to go below the haptic which is under the iris and then come back out through the other side. You don't need a 26 gauge needle at all. You can simply go in through just the straight needle. And here it is a single pass 4-throw suturing technique that has been done. We thread we thread it with the single pass 4-throw technique and we secure the knot. Now the same is done on the other side. You can use the spatula to maybe even pull the IOL a little up so that the haptic is more prominent under the iris and you can then look at it and thread it. Again, in the end, we want to make sure that the anterior chamber is away from any vitreous. We felt that there was a little bit of a strand before suturing, so we stained it with triamcinolone and then we took it away, sutured it, and in the end, you can just clear the anterior chamber. Once we have tightened both the knots, then we now tuck the optic back. We can do the little bit of vitrectomy that is required for the vitreous to go. Here there is no real vitreous loss that we found. That's why there was no core vitrectomy or anything else that was attempted. We clean the viscoelastic that may have been left behind. You can pull a little bit at the iris to make it more circular so that the pupil is more circular. And then we cut the 90 Prolene suture with the micro scissors, and that's the end of the surgery. So the iris is a good anatomical structure to use when fixing IOLs. Now whether to use an iris claw or to suture a lens really depends on some factors. So I think as a primary surgeon, if there is poor capsular support, it may be better to use an iris claw, especially if you're an anterior segment surgeon and want to stay away from the vitreous. But if it's a dislocated 3-piece lens and you want to keep the manipulations less by taking it out and then replacing it with something else, I think it would be a good idea to do an iris fixation suture. And we should be at that time understanding whether we want to do a minimal vitrectomy or we would involve a vitreoretinal support to help us do so. So ultimately, I think the choice of IOL depends on many things, but this is a fairly good algorithm to follow, and we are going to see the other techniques of how to do what when the bag is in there. Thank you so much, and I'm sorry for the technical issues.
Thank you, Dr. Tanvi. One quick question for you is, we saw you beautifully doing the iris fixated IOL without ovalization of the pupil, which is one of the commonest complications of iris claw. How do you prevent that?
I think to take a little bit peripheral is important, and sometimes the way you put the side ports, that's probably what helps us take the suture easily. If you have taken it, if the side port is not exactly angled correctly, you will end up taking a mid peripheral bite, and then that's going to take or pull the iris tissue a little more towards the periphery.
Right.
So before you even tighten it, maybe you can just pull the pupil a little bit and then tighten the suture.
And the similar trick for the iris claw IOL also?
Yeah, for the to stay a little. Yeah, I think. But like I said, initially we've all done this. It's only the technique as you grow better, it becomes better. These are surgeries which I've done towards the end, not my beginning ones.
That's nice.